Hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia in Australia. In this episode, I am chatting with Dr. Doug Hacking, an anaesthetist from Melbourne, and we are discussing his editorial from the September issue of Anaesthesia and Intensive Care on GLP-1 receptor agonists. Prior to entering anaesthesia, Dr. Hacking was a clinician, academic, researcher, paediatrician, and he shares some insights into how to juggle a clinical and research career, as well as some considerations for changing medical careers, because he's now an anaesthetist. That editorial was the editor's choice for that edition of Anaesthesia and Intensive Care, which meant that for 1 month, if you're not a subscriber or you don't have access to it through your ASA membership, then you had free access to it. So do keep an eye out. Before we get into the conversation, I wanted to share some thoughts on speaking, voice work, and giving presentations. By way of background, the idea for sharing these thought bubbles came from you guys out there, our fabulous listeners who approached me at the NSC and asked various questions. So I'm sharing with you more broadly some of the answers. So far in this series, I've discussed using your late night radio FM DJ voice to project calm and confidence. I've encouraged you to use this voice when introducing yourself, in particular when saying your name. I've elaborated on that and asked that you introduce yourself, say your name, your role, whatever, without interruption. And also, thanks to the guest host on our last podcast, I've talked about vocal fry and its potential significance in detracting from your authority and charisma. Today, in what will be the last of this little series of vignettes, I want to elaborate on what you can say to help smooth out your introduction further. So at the start of episode 109, that was the one with past President Bob Hare, I talked about saying your name, introducing yourself without interruption. So just saying, hello, my name is Susie New and I'm an anaesthetist from Melbourne. No ums in there, no clicks, like no, hello, my name is Susie New, and I'm an what am I, anaesthetist, you get the idea. So hopefully you're saying that with confidence and it's slick, and then you might get to the point of wondering what you're going to say next, and that is where the might come in. And I want you to think at that point, instead of saying say thank you. I think there's a good reason why often at conferences the presenters, after introducing themselves, will often say a thank you to the organisers or a thank you to the chair that's just introduced them. It's a wonderful moment to gather yourself, gather your thoughts, sound confident and be gracious. There's been a lot written and said about the power of saying thank you in terms of building respect, strengthening relationships, improving motivation. So I suggest get out there and say it with authenticity. And with that, I want to thank Dr. Doug Hacking for giving up his time, sharing his expertise and joining me on this podcast. I want to also mention that at the end of the episode, I'll be sharing a special offer, an exclusive offer that can save you hundreds of dollars for those of you who are interested in gastric ultrasound. But for now, let's get into it. Thanks for connecting this morning. I wanted to, first of all, we're going to be talking about the editorial that you were involved with writing for the recent edition of Anaesthesia and Intensive Care. But before we go into that, I wanted to find out a little bit more about you. So you're an anaesthetist here in Melbourne, is that right?
Yeah, I'm a staff anaesthetist at the Austin Hospital, been here for about 10 years. I'm a specialist interest in bariatric anaesthetics, onco-anaesthesia and paediatric anaesthetics. And prior to my being an anaesthetist, I was a paediatrician at one point.
Oh, really?
The whole debate about obesity in childhood is obviously quite close to my heart. It is the feeder, if you like, for a lot of the problems that we're going to encounter in the adult world.
I think you're probably only the second person I know who's a paediatrician who's become an anaesthetist. Can I just find out a little bit more about that? When and where were you a paediatrician?
I was a paediatrician, trained in the UK, in Alder Hey in Liverpool, and I trained also in Melbourne at the Mercy and also the Royal Children's Hospital. I was a consultant of women's for a very short period of time, and I converted to anaesthetics in about 2012.
And what stage of your paediatric career were you at when you decided to change into anaesthesia?
I was a consultant at that time. I was a clinical academic, so I was doing a lot of work. My wider background is I trained in undergraduate medicine in Oxford. I then did some paediatrics, came to Australia, went back to Oxford, did a PhD, and then came back out to Australia and did a postdoctorate at the WEHI, looking at embryonic factors associated with survival of fetuses. I did that for about 3 or 4 years and then decided to convert to anaesthesia. And I took about 3 to 5 years to do training, and I've been working at the Austin since that time.
That's so fascinating. What made you decide to go into anaesthesia?
We, at that stage, were a clinical academic household, and it's an enthrallingly interesting life, but the salaries are somewhat unstable in that you are always going for the next grant. And if you're trying to run a household, you need to have a stable income and an unstable income. And so it would make more sense for me to pick up a job where I was able procedurally to do it and run a clinical course. And so the other part of the team was running an academic course.
And when you say it was more suited for you?
I think staying on the academic career ladder, it was very difficult doing fundamental basic science and the clinical specialty. So those people who do really well have a research base which is quite closely aligned to their clinical base. So if you're doing MRI research on neonatal brain development, then you can apply that clinically. If your research area is quite a long way from your clinical interest, then you're effectively running two disparate and separate careers, and that's much more exacting. So those people who take those paths tend to want to do full-time academic stuff and run their own lab, and I didn't want to do that. And it didn't make much sense for the household at the time for me to do that. So it was much better for me to take a clinical path than continue down the neonatal route, which is where I was at the moment. And I think in many ways, neonates has become less and less of an intensive care specialty in some ways because lots of babies are getting better with CPAP and less intervention rather than more. And the traditional intensive care anesthesia part of the critical care spectrum suited me much better. That was always my bent, really. I think that the more traditional approach was better suited to my skill set, if you like.
And I've heard that often said when I've talked with academic or scientists, clinicians, that it can be really hard to juggle those two careers and also get respect from peers in each side of those careers. So I think you've articulated, I've never really thought about it before, that having them really closely aligned helps you keep that marriage happy, I suppose, in a way within your career.
Yeah, I've got a number of colleagues who've done really good work on respiratory research and they can apply that to their clinical lives. Now, there are other really good researchers I know who have made a fantastic career, but they've become full-time bench lab people and they've left the clinical side behind. And I think the demands of clinical academia these days are very high in that you have to be across all the administrative aspects of running a lab and competing, at each stage, there's only 5 to 10% of people are going to get those fellowships. And that becomes harder and harder over time. I think the academic community are the hardest working and the most productive and the least rewarded civil servants across the world, really. And I am a strong advocate for what scientists do, what they provide, but also the sacrifices they make in order to achieve that and the difficulty they have in terms of maintaining that research output.
As you said, that uncertainty with going from grant to grant and the competition. And then was it hard to go from there to back into the hospital pathway, finding a clinical job? You're an expert in your field and now you're being told how to tape in IV drips and things like that.
I think there is great benefit from people who've got multiple skills. Those people who have multiple fellowships, so physician, ICU, anesthesia, are immensely helpful in terms of their contribution because they cover the waterfront. The timing in which you take that on, I think, is important. I think you're most adaptable in your 20s and 30s. And you also cope with sleep deprivation and the nights better at that time. As you move into your 40s, that your adaptation physically, but your adaptation is reduced. I think the psyche you need is not only to be a good leader, but to be a good follower.
For sure.
And I think most of us in our working lives understand the importance of swapping between those roles. I think it is very demanding, certainly coming from quite a narrow specialty to moving to a specialty where you're required to think about all of the adult conditions again, because neonates have a limited range of things which can go wrong with them. And neonatologists are very good at managing a small number of conditions and doing that very well.
Yeah.
And it also is a specialty which lends itself to research because a large cohorts of neonates, all of whom have got the same problem, and you don't have the same heterogeneity you have in adult or paediatric intensive care.
For sure.
So I think you have to have lots of energy and you have to have lots of humility. And yes, it is tough because your subconscious expects yourself to be at the same level you were in your new specialty as the one when you left. And of course, that's not the case because you're going to be learning the ropes in the same way that you had to in your 20s.
Yeah.
And doing exams with small children, again, is not easy.
Definitely. Yeah.
I think what I can add to the specialty, having done both, is much greater. But the cost of transfer, is not only financial cost, but emotional cost and cost your family to some extent, is something I think I underestimated before I made that journey, because I just thought I was going to be another postdoc 3 years and I'll be at this different place. But I think the 10,000 hour adage is probably truer. And 10,000 hours is 5 years of work, of full-time work. And I think in reality, to get your hand across each specialty, you really need to be doing it for 5 years.
Yeah.
And towards the end of the time, I was really enjoying it.
Oh, good.
But in the training process, the beginning stage, it was bewildering and emotionally demanding and tricky, really, I think.
Full kudos to you, because I had a conversation with someone else on another podcast actually about transitions and the things that we go through. You're not the same person when you're a registrar as compared to being a resident. And once you cross that border into becoming a specialist or a consultant, it's hard. You've crossed that boundary in a way. And then to go back and do it in another specialty, I think, as you say, a lot of humility required and very humbling. So it sounded like you were clinically full-time in NICU and you're now at the Austin, which from my understanding doesn't do a lot of paediatrics.
We have a paediatric service here. We have a catchment area which has lots of kids coming through ED, but we have a relatively small paediatric service. There's no doubt about it. I ended up at the Austin by serendipity, really, because I did a paediatric fellowship at the Children's in paediatric intensive care and anaesthesia. I did a job at PEDMAC, which I loved, to make sure that my adult anaesthetic skills were as well catered for. And that went very well. And I think there is an element in which you have to transfer the skills and to really utilize the present. You can't be stuck in the past. You have to embrace what you have in front of you. And I do lead up the paediatric service here and liaise with the kids as much as I do. So I still maintain those skills.
It sounds like at least you've got your hand in paediatrics still. You haven't given it completely away.
That's true. I still do that. But the core principles about neonates, it's all about precision of delivery and precision of procedural techniques. And those translate to anaesthesia very well, those core principles. And it was an anaesthetist I'd worked with in NICU who persuaded me to jump. You're giving drugs to an individual to engender a new state or an altered state, so that you can treat their other diseases. And so in a way, they're quite similar. And lots of anaesthetists rotate through PICUs and NICUs and adult intensive care for that reason.
Exactly. I want to move on to what we're meant to be talking about, which is the GLP-1 receptor agonists. You mentioned it briefly at the start about coming from paediatrics as a background, neonates in particular, but your other big clinical area of interest is bariatric anaesthesia. So how do you relate those?
Well, my smallest patient was 320 grams and my biggest patient is 360 kilos. So there's 1,000-fold difference in one species between those two states. They're both at risk of premature death, but for very different reasons. And they relate to societal change. We've had very significant societal change in terms of what age we have babies and what assistance we have with having those babies, which predicate towards prematurity. And we've also had enormous societal change in terms of how we eat, how we choose to eat. And that change has been occurring since the 1970s, by and large. But there's an excellent podcast in the New England Journal with Darish Musafarian, where he talks about the advent of highly processed foods and why they became prominent in the 1950s, because people who designed them had memories of the Great Depression. So they had memories of people being starving. The idea was to have foods which did not go off, didn't decay effectively, which were readily available in packets, which were high in calories and high in fat, which would stop people being hungry, who are doing very labor-intensive jobs. And that was a laudable aspiration in the 1950s. The difficulty came when the doctor's smoking study came out from Oxford in the late 50s. The tobacco companies realized that writing was on the wall and they diversified their assets to buy up food companies, and they applied the marketing strategies to tobacco, to food. And that's why we see this big escalation in obesity from the 1970s. And then you couple that with sedentary lifestyles, both professional and recreational. So professional, we're sitting down a lot in the service industries, but in recreational, people are gaming a lot more, on computers more, as opposed to being outside. And then sleep hygiene. And then you have this sort of perfect storm of obesity, if you like, which is taking off and becoming an ever greater problem for us to deal with, which has enormous implications for neonates. Because if your mother's diabetic, then you're much more likely to have difficulty delivering. But it's got a much, much bigger part in terms of the overall escalation of health. And I would point out that the pro-inflammatory state of obesity takes hold well before you've got metabolic syndrome. So studies of premature aging in children and adolescents show that the longer you're obese, the more premature aging you get. So your epigenetic markers, your telomere lengths all start narrowing from the time when you were obese. So if you're obese since your childhood and you're in your 20s now, you will have premature aging for that duration. And that'll be worse than if you were obese from adolescence. And we know that if you were obese between the ages of 2 and 8, you're much more likely to be obese in adolescence and much more likely to be obese in adulthood. So those two things taken together mean that we have to stem the tide of adolescent obesity. Japan does that very well. It has a dietitian in every school. They have no highly processed foods.
Wow.
They have an early intervention program for obesity. And so the Ozempic rates or the GLP rates in Japan are very, very low. France has a falling level of obesity within adolescents, which is fantastic. Some of that is due to smoking, which is an appetite suppressant. But it's also to do with the relationship with both Japan and France have with food.
Yeah.
The idea of slow eating, that relationship of high quality foods, portion control, eaten slowly, mindfully, if you like, is part of the issue. And we slightly lost that in the West to some degree.
Yeah, for sure. There's been those studies that also show that if a pregnant woman is overweight or obese, she's much more likely to have a child who's going to have issues with obesity.
Really, no question. And insulin is an anabolic hormone. So if maternal serum glucose is high, then the insulin in the infant will be higher, which means that that infant will be bigger. And that's a much bigger problem in terms of paediatrician, but it's also a bigger problem in terms of their subsequent clinical course through life, I think.
I did hear from one group, this is moving on to the GLP-1 receptor agonists, and it's probably related, as you said in the article, about how obesity is multi-organ, multi-systemic. So I did hear that they estimate with the benefits that people are finding from the GLP-1 receptor agonists, that we could have up to 50% of the population on them, not strictly for either diabetes or weight management, but for the dementia prevention, for the cardiovascular benefits, for a whole host of other benefits that are now being discovered or increasingly being discovered. Do you think it will get to that prevalence?
It could well do. And I think we need to go back to where does obesity sit within the changes in society. And there are a lot of companies which have made, as a marketing strategy, dopamine as the center point. So dopamine in your mesolimbic system. And what we found when people on GLPs, it not only increased their insulin, which is good, it lowered their glucagon, so they had better diabetic control, and it slowed their gastric emptying, so if they felt less hungry, they didn't want to eat. But what was fascinating was what they chose to eat. And they chose to eat sort of boiled vegetables. They didn't want to eat high fat. It wasn't just portion control. And so those dopaminergic hits you would have in terms of your food choices were different. And then we noticed that they drank less alcohol. They started screening on the internet less. They gambled less. And so by controlling that dopaminergic pathway, they effectively had choice back in their lives. And that is the reason why so many people will enjoy them, not only for weight loss, but in terms of the absence of that dopaminergic urge. And when we think about the pattern of addiction, addiction starts with serotonin, which is the like, and then it moves on to the want, which is dopamine. And that's called the dark side of addiction. That's the point where you're no longer enjoying the addiction, but you've got to have it. And the GLPs will disrupt that. I think there is also a lot of stigma we have against people who are on GLPs when they're thin. And I think it's a failure to understand the other effects of these drugs. But it's also a sort of a part of the ongoing stigma where somebody who's thin, who's on a statin, for instance, we don't judge them that they're on a statin. We think that is wise. And yet we do make judgments about people who are on GLPs. And so it's part of the paradox of how we regard obesity in society. And one of the things that obese patients really struggle from is the reaction they encounter outside. And even within hospitals, that bariatric services are the first to be cut. And so I think it's that the GLP's central actions, which are the most interesting. And it does come into effect, particularly within adolescent metabolic and bariatric surgery, because many adolescents who become morbidly obese have psychological problems underlying it, and they may have concurrent alcohol abuse. And bariatric surgery makes adolescents healthier but not happier. So they may have more psychiatric input post-surgery than they had before, and they may have more alcohol abuse afterwards than before. And so GLPs are excellent in not only avoiding weight gain after surgery, so medical and surgical work better, but also in reducing alcohol use disorder post-surgery.
What is your takeaway? What do you think is your key wish that anaesthetists would do with GLPs in the perioperative setting?
Well, my message is one of sympathy and empathy, in that we understand that obesity makes anaesthesia much more difficult. And so as anaesthetists, it is much easier for us to have patients who are not morbidly obese, because all of the complications of access, intubations, ventilation, having a heart which is effectively feeding 4 people. So it's much more challenging in many ways. So GLPs are our friend to some extent, but it's also that the anaesthetic community is going to carry the burden for GLP-mediated weight loss, in that the existing screening measures to see whether people have got full stomachs or not are inexact. We've got some data to suggest that 24-hour fasting is better, but it doesn't completely alleviate the problem. There's going to be a big difficulty in terms of getting gastric ultrasound up. You're going to have to do 50 of those at least before you're confident. Using erythromycin, it's effective, but it's not necessarily practical. It takes an hour to be delivered and then another hour to work. So that's 2 hours on a big list. RSIs clearly have their complications, and we were going to have anaphylactic events relating to sugammadex, rocuronium. So effectively, we're presented with a Hobson's choice. But Hobson's choice is from a stable owner in the 16th century in the United Kingdom, where he said you could have any horse in the stable provided it's the horse closest to the door. So you're presented with a choice which isn't a choice.
Yeah.
And we, anaesthetic community, are being presented with a choice which isn't a choice. Clearly, it's not a choice. We have to deal with the obesity epidemic, but the means by which we're dealing with it, both in terms of surgery, be it gastric sleeves or GLPs, are going to increase the aspiration risk. And it's all very well for people like me who do big case anesthesia, and I do lots of bariatric work, and we can accommodate that. But if you're doing a high throughput urology list, that's really hard. And if 50% of your patients are on GLPs, that's really difficult. And I think that technical challenge was underestimated in the drawing up of the guidelines first. So my sympathy is with hardworking anaesthetists out there who have high caseloads, who are very skilled, who are looking at how these agents are going to affect their day-to-day work. We're going to have to adapt. And that is the difficulty. We are going to have to consent on patients much more closely and say, look, great you're losing weight, great that you feel that you've got choice back, but your risk is going to be higher. And we need to educate the public about that to some degree, that this is the price of weight loss.
Yeah, exactly. It does remind me, I don't know if you were in clinical anaesthesia, but I remember when I was a trainee, most of my patients back then easily had BMIs under 30, most probably a BMI under 25. And I remember we were watching the numbers, the obesity epidemic coming. We could see it occurring in America. We knew that in Australia we were maybe a decade behind. We were talking to our American colleagues. They were telling us about needing bigger operating tables that could take patients of greater weight, having special bariatric tables for people with the big BMIs over 45, 50. And I remember you'd get a patient with a BMI of 30 and it would be, we can't use an LMA in someone with a BMI over 30. It's not been established that this is safe to do. And if you did get a patient with a BMI over 30, you were anticipating a difficult airway, and this was kind of a slightly daunting patient, not, challenging. And now I can't think of a day where I don't anaesthetize someone with a BMI under 30, and it just becomes bread and butter. So the adaptation has occurred in that regard, and I can't see any other way. I think we will have to also adapt to GLP-1s being part of the general milieu of our patients.
I think that's true. I mean, it's interesting that the obesity classification, has moved from obese and morbidly obese and super obese to obesity class 5, and obesity class 5 is right up there in terms of people who have BMIs of 60. And, I've got a patient who's got a BMI of 100, and, many of the patients we have through the Austin, have got BMIs of 80. And that is truly challenging anaesthesia, both in terms of getting access and ventilation and so on. But we're all bariatric anaesthetists, but I think it's like standing on the beach and seeing this rising tsunami of problems coming hitting the beach bit. Yeah. Demographic, but I think there's a real understanding that the situation is unsustainable and we have to change. And I think it's important to also reflect on how miserable it is to be in this pattern of weight gains you can't control. So I think we have to help these patients because they're living a life which is very, very diminished, and it's not helped by the social stigma, and we really have to help them have a much more fulfilling life where they seek out that help. And we can't allow a generation of children to move into that epoch because they will be prematurely aging, and that will have implications for our healthcare systems. I mean, we had a patient through recently who had a relatively normal BMI, but he was sarcopenic, he was a gamer, he sits on the sofa all day, and he's having a disc done in his 20s.
Wow.
And he's got no muscle mass at all. So it's the absence of lean body mass, which is the thing which really scares me, because lean body mass offsets a lot of these problems. And we're having a whole group of people who are starting stroke volume, the starting cardiovascular capacity is really low. I remember being taught by Roger Bannister at Oxford, and he was the first man to do the 4-minute mile. And he describes his ability to be able to run that to the fact that he lived on a farm and he had to run to school. He could catch the bus, but it was slower, so he just ran to school over these hilly areas. In that time of adolescence, he developed this great cardiovascular capacity.
Yes.
And it stayed with him through his whole life to the point where he was able to do something tremendous. But we're now looking at a gaming generation where their starting cardiovascular output is really low and they're prematurely aging. And so we have to do something. We have to act quickly. Medical intervention is part of that. Diet is obviously lifestyle factors, but GLPs are undoubtedly a part of that connection. But I also think we have to have some understanding on the part of government, be you left or right, that this is an area we need to act on. We can't be left to voluntary codes. In the same way that we've legislated against cigarettes, we do need an opinion from government and support from government, I think.
That ties into some of the work that the AMA is doing about trying to introduce a sugar tax and reduce the ease with which some of these foods become available.
Yeah, I think we do. As advocates for our patients, we do have to advocate to our political leaders to say, look, something does need to be done.
Yeah. For a long time, we've put the onus on the individual. And we've said, it's your problem that you've been putting on weight. You've been eating too much and not spending enough energy. It's energy in, energy out. But I do think that approach hasn't necessarily helped. In fact, it hasn't, looking at the epidemiology. And we do, as a community, need to act, and we do need to ask our political leaders to enact things on our behalf.
I think we need to look back at the history of this, in that there wasn't some collective collapse in moral fortitude in the mid-1970s, which resulted in obesity. It came about of the very deliberate marketing strategy by applying the marketing of cigarettes, the techniques you can market cigarettes to food. And we've been very effective at applying government legislation to bringing down cigarettes. Yes, there is a moral choice about cigarette smoking, and we have to have that. But we've also provided an infrastructure which makes it easier. The olive green cupboards, the graphic photographs, peripheral vascular disease, and the taxation on tobacco. And unfortunately, with food, we need to do a little bit more of that, make healthy foods more accessible, cheaper, and work with the population so they can live happier and healthier lives. And France has fantastic food, but they have...
Oh, it does. So does Japan.
As does Japan. Yeah, but they have portion control and they think about it carefully. And I'm not interested in creating a puritanical world where people don't enjoy themselves anymore. Absolutely not. But I just want people to enjoy themselves for longer and healthier.
Yeah, and it has the benefit it would make our job slightly easier.
So, yes, indeed.
Look, maybe on that note, we'll leave it there. Is there anything else that you would like to say? It's been just a fascinating conversation. I feel like I could dive into this for a lot longer with you.
Well, I think ultimately we all want the same things. I think that we would like choice in our lives. We'd like to enjoy food, but we don't want to have the harmful effects of food. And we want to go back to a stage where we can make meaningful decisions, whether we're not strongly influenced by dopaminergic rush in lots of aspects of our lives. And I think the whole GLP therapy has opened up this debate in a very significant way in terms of alcohol, binge eating, and so on. So I think that to me is the take-home marker, is how can you have balance and choice within your life in the current environment, marketing environment, and how can we achieve that best?
Well, lovely. They're lovely words, and I'd love your overall sentiment of empathy and sympathy for our colleagues and also for our patients. Thank you so much, Doug, for your time this morning.
It's been a pleasure.
Well, I hope you enjoyed getting to know Dr. Hacking and hearing his thoughts on GLP-1 receptor agonists. To me, it was an unexpected surprise and such a delight to find out more about juggling an academic research career with a clinical one, and also what it's like to change specialties. There's only a few people I know who have done that. So for those of you out there who might be considering research as a career or even changing specialties, I hope you found that useful. Doug did mention a New England Journal of Medicine podcast with Professor Darush Mozaffarian, which I found on YouTube. There's some really interesting thoughts in there about what different jurisdictions are doing in terms of limiting exposure to ultra-processed foods. I hope you've heard of here in Australia, the AMA's campaign to introduce a tax on sugar on processed foods and drinks. Well, that, compared to what he says in the podcast, seems like such a small step when compared to what is going on elsewhere. So I'll put a link to that in the show notes. I'm really intrigued by those ideas on ultra-processed foods, and I do hope to dive in a little bit further on this topic in a podcast in the future. Now, I did mention at the start that I was going to share with you a special offer. I know with the rise of GLP-1s in the community, there has been an increase in interest in gastric ultrasound. Every conference, every hospital education session this year seems to have or want to include a workshop on gastric ultrasound, and I think there's very good reason for that. I've done my gastric ultrasound workshop, and I know many of you guys have done that out there as well. So many of us have been wondering what the role of gastric point-of-care ultrasound will be in our practice and how many we might need to do to have the knowledge and the skill to use it with confidence. I know some of us out there are huge proponents of gastric ultrasound and have undertaken further upskilling, and that leads me to our special offer. The American Society of Anaesthesiologists offer a certificate in gastric point-of-care ultrasound. The certificate program includes mentoring, online training, you'll need to practice gastric ultrasound skills, and also take a final exam. It's a robust offering, and from what I've heard at the time of recording, it might be the only one in the world of this calibre. So I'm pleased to share with you an exclusive offer. If you are a member of the Australian Society of Anaesthetists, then you are able to register for the course at the American Society of Anaesthesiologists member rate. What does that mean? That's a 35% discount, which is pretty significant given the course is usually about $530. So that's a huge saving. I'll put a link to the course in the show notes so you can find out more. You can read up about the course and work out whether it's right for you. ASA members, if you want to register, then keep an eye out in your emails for the details. If you can't find those details, feel free to email me on podcast@asa.org.au and I can share them with you. As I said, you do need to be an ASA member to be eligible for that offer. If you're interested in joining the ASA to access that offer, as well as many of the other benefits of ASA membership, then please visit our website, asa.org.au for more. Of course, I'll put a link to that in the show notes. I hope you find that news a little bit exciting. I have another offer, which I hope to announce in the next episode of the podcast. I feel like I do like handing out a bit of generosity as we lead into Christmas. Anyway, in the meantime, I hope you're enjoying this time of year. I hope it's not too crazy, not too busy. I hope you are getting out there, spending some quality time with some friends and family, or even just having some peer support and M&Ms as we're trying to fit in all our CPD requirements. As always, I hope you and your patients are staying safe and well out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr. Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.